Joining us this morning, once again, to talk a little bit about the COVID situation in New Mexico, and specifically Farmington, San Juan County, and San Juan Regional Medical Center. Friends of the show.
Friends of the show.
And they're back, and we couldn't be happier, right? Dr. Erin Philpott and Dr. Brad Greenberg from San Juan Regional Medical Center. Welcome, both of you, on the phone this morning. It's great to have you with us.
Good morning. Thanks for having us.
Very welcome. I guess let's start with both of you. And Dr. Greenberg, maybe you can start for me about talking about the hospitalizations. We have heard, and I think this is true, obviously, that hospitalizations are down at San Juan Regional and around our state. Numbers seem to be still down. San Juan County is at turquoise, which we're all thrilled about. And so, A, is that still true? And then B, the focus now turns to some of these long-haul COVID patients, and how are they doing, and what's the thinking about treating them?
Well, that's a great question, and it's something that we actually are very happy to see is a decrease in overall case counts at our facility. So we've actually, we were looking at some of the older data, and we really had peaked somewhere just a little bit higher than 100 patients, 100 COVID patients in the facility several months ago, and today it looks like we have a combination of both PUIs and COVID positive patients of only 20, which is very reassuring. So we're definitely trying to reposition all the resources within the hospital to do two real important things. One is to address an increase in non-COVID volumes, and the other is really to make sure that we maintain a safe environment of care and we remain poised to cope with any of the unforeseen circumstances that could happen in the near future. Even though, as we're very happy to see our case counts decrease, we're cognizant of what's happening around the world, in Europe, and also around the country with increasing case counts and increasing hospitalizations in some regions of the country. So far, New Mexico seems to continue to trend downward, and the emphasis has really been on vaccination and trying to reopen things. But in other places in the country, especially the upper Midwest and Michigan in particular, as well as New York and New Jersey, I've seen much increased cases, which makes everyone real concerned. So we're trying to enjoy the decrease in the case counts, take a big, deep breath, prepare for non-COVID volumes, and remain prepared for what may come.
Good to know. And in these long-haul patients, because we know we've had thousands of patients in our state, in our county, that have contracted COVID and somewhat recovered from, but some still have some serious health conditions, correct?
Yes, that's exactly right, Scott. We are definitely shifting our efforts as we are freeing up a little bit more time as we've gotten through this very large last surge to focus on what we can do to support these patients who are experiencing these long haul symptoms or these long COVID symptoms. And just to remind us kind of how we're defining these different stages. Acute COVID is up to 4 weeks, symptoms up to 4 weeks. And then there's this sort of in-between phase of ongoing symptomatic COVID, which lasts up to a total of 12 weeks. And then after 12 weeks is sort of the formal definition that's emerging of post-COVID or long haul COVID. Many different names have been emerging across the world to describe sort of these different clinical symptoms. And it should be noted the stages are reflective of the symptoms, but not related to actual viral infection or infectivity or transmissibility. There's been lots of interesting studies that have been done looking at these different symptoms, which most commonly include fatigue, weakness, really poor endurance, just not feeling like you can get through your day. Of course, the shortness of breath, chronic cough, chest pain or discomfort, and then some interesting neurologic and psychological symptoms, including the altered taste and smell, and then anxiety, depression, PTSD, and even in some severe cases, psychosis. Some risk factors include, these can happen, people who never require hospitalization. But more commonly, we're finding these longer symptom courses are among people who were hospitalized, and especially in the intensive care unit. Older age also predisposes you to long COVID, and then any other pre-existing medical conditions like diabetes or high blood pressure. And another risk factor is those who have had other complications of COVID, like, for example, a bacterial pneumonia on top of their coronavirus or a blood clot. So there's lots of different symptoms, which I think is important to understand when we talk about the treatment. There was an interesting story recently in the New York Times about a gentleman, a ex-Marine, who had developed a florid psychosis after his COVID illness and actually required inpatient hospitalization. So the treatment for that is obviously very dramatically different than someone who has sort of exertional chest discomfort or a shortness of breath. We've talked much about these different symptoms among our team here and how we can best support our community, as you mentioned, given our substantial number of post-COVID patients now. We've talked with UNM. They have a physician champion there that's sort of coordinating care among specialists for patients who are having different long-term severe symptoms. And ultimately, the best course is, number one, the treatment is supportive. So that just means we don't have, a magic pill like penicillin for strep throat, but it's rather to support the symptoms like the psychosis, to treat with our known treatments, or to treat it with what we already have in our toolbox, like antipsychotics. And then should have said the first most important thing is long COVID. Symptoms of long COVID are a diagnosis of exclusion. We've seen a lot of sort of collateral damage from the pandemic in our healthcare system and infrastructure, meaning that we had to rapidly shift from inpatient clinic visits to telemedicine visits or even phone visits who didn't have the technology. So we didn't have a lot of prep or planning time to sort of anticipate the impacts of some of these things. And we're finding that people, like, for example, someone with shortness of breath, we need to make sure it wasn't just that they missed their heart failure medicines over the last 3 months, or someone with fatigue doesn't now have new undiagnosed, uncontrolled diabetes, and so on and so forth. And these things are commonly identified at in-person clinic visits, or even at visits that you come to get, your respiratory illness addressed, of which we haven't seen much of this year. So we've seen a further reduction of visits. So in sum, that's a lot to take in, but I think the most important piece is first rule out other causes of these symptoms that you suspect are long COVID, and second, supportive therapy remains the mainstay of therapy. And one final point, there's been some recent suggestion, and we've been hearing stories about the administration of the COVID vaccine possibly improving some of these long COVID symptoms. To my knowledge, there have been no formal studies to date. However, it is actively being looked at. And there's a couple emerging theories coming out of that, one of which is the vaccine, the immune system's response to the vaccine is boosting the immune system and allowing sort of this clearance of the virus that may have been just kind of a low level in some organs causing some of these long COVID symptoms. And then the second theory, and these are by no means proven, just very theoretical at this point, is that long COVID is a type of autoimmune disease, which means just that your own body is kind of attacking you and causing some of these symptoms. And the administration of the vaccine may help it kind of reset in some way and reduce this autoimmunity.
Very good. Thanks for nerding out and providing such a thorough answer. You know how I especially love that. So
I think you were nerding out.
Yeah, I was like scribbling notes over here.
Yes.
Anyway.
The doctors were sharing important information for our audiences.
Yeah.
Yes.
Very clear. Very good. So let's talk about the variants. The UK variant has now shown up in all 50 states. Our sister local news program, Farmington Daily Times, reported this morning that, one case was found on the Navajo Nation and that individual was hospitalized. So can you give us an update on all the various variants showing up? We'll start with you, Dr. Greenberg.
Absolutely. So the UK variant, so the B117 variant, is thought to have started in the United Kingdom. And there is the concerning features with this are that, well, really, from an epidemiologic standpoint, we're very concerned that it may be more transmissible than other forms of COVID that we've been used to for some time. And in addition, some of the research has also demonstrated that the cases may be more severe and there may be a higher mortality associated with it. The good news is that the existing vaccinations that we have on the market available to us, Pfizer, Moderna, and J&J, all seem to demonstrate adequate protective effects as it relates to the UK variant. So that's reassuring. Now, the problem is that we're starting to see increasing numbers of cases and an increasing proportion of new cases in those areas that are demonstrating much higher incidence of new COVID cases now. So the numbers in Michigan, there's a large proportion of those that are related to B117, and the numbers in New York also seem to be related to B117. There have been sporadic cases, as you mentioned, Megan, around the country of B117 that is it's concerning. And in Europe, when that proportion of new cases approached approximately 50% of the new variant, it really looked like a tipping point where there was a much larger surge that followed. So we're following the epidemiology associated with this particular variant very closely, and trying to really encourage folks to stick to COVID-safe practices and go and get that vaccine. I think that's super important. The other variants that we have seen, the South African and the Brazilian variants, there's ongoing surveillance within the state of New Mexico and across the country, and there have been sporadic cases of both, around within the United States. Now, my understanding is that the South African variant may have be a slightly diminished effect of the existing vaccines. Not to say that they're rendered not useful, but they may be slightly diminished effect. And then I'm not sure, perhaps Dr. Philpott has seen any specific vaccine-related information as it relates to the Brazil variant. I know that now, though, the variant discussions have focused largely on the UK variant because it looks like that's really the problems we have at hand. But I do think that one thing that I want to make sure that everyone understands is that the best way to prevent variants and to not get sick is to do the things that you've been doing for the last year. Wash your hands, wear a mask, cover your cough, appropriately socially distance. And now the most important thing here is go out and get that vaccine when it's available to you.
Thank you. Very good. Dr. Philpott?
Yes, I think Dr. Greenberg pretty well covered it. I would just add, I echo that the sentiment and the imperative that the vaccine is the most important way to reduce further development of variants, as this is just the natural evolution of viruses. And reduced cases equals reduced opportunity for the virus to find its niche in a new way. The P1, which I think the general consensus is not to associate the variants with the countries, because we're not even sure, if that's exactly where they grew or developed, and it can just, I guess, create issues. But anyway, the P1 variant, I know there is some concern that the vaccines won't be as effective against it, based on some of the data down in Amazonas, where a large proportion of the population was first infected, and many are now getting reinfected with this P1 variant. So there's some concern that the mRNA vaccines developed kind of based on the first viral sequence may not be effective, or may be significantly less effective against it. But yep, just social distancing, vaccination, and let's reduce the spread.
There you go. And doctors, let me ask you both then, it seems like we're kind of in a race against time, though, with getting the vaccines rolled out to as many folks as we can. and then hearing about the spread of these variants and things along that line to really try to get these cases back down to where we want them, and even to go away entirely, which certainly we all are anxiously awaiting for. Dr. Greenberg, is that kind of how you see it too? Is kind of this race against time with these variants and these increasing case numbers and the vaccine rollouts in the States and the world?
That's absolutely how I see it, Scott. I think that, as Dr. Philpott mentioned, it's the natural course of things for viruses to change over time and to mutate. And if and when provided the opportunity to reproduce within a particular host, they change over time. They make errors. And so the best way to prevent the creation of new ones or create the spread of existing variants is to do, like I mentioned, all the things that we've already been doing. So the vaccination is a pressing thing. I think that we should all get out there, and when it's available to us, and how great and what a great time it is that today they released the phase 2 for those folks that are 16 and older to get appropriate vaccines. Within the state of New Mexico, it's just such an important and timely thing for folks to go do. Get that vaccine, stay conscientious, continue to wash your hands, continue to wear a mask where appropriate, continue to socially distance where appropriate, and that way we can sort of continue to maintain the progress that we've made, and try to avoid a recurrence of what's happened in the last several months.
Very good. And sort of drafting on the race to vaccinate, there's been a lot of controversy around Astrazeneca, which is not currently being used in the United States. Dr. Philpott, maybe you can give us an update on that and explain that for us a bit.
Sure, yeah. So the AstraZeneca vaccine has been associated or has been put on hold in several countries due to a concern with this association with a rare occurrence of blood clots in some younger adults. And I think, correlation is not causation, and it's really important to highlight that in this situation. We can assess the risk of acquiring COVID and the complications thereof, including possible death for some of these high-risk people versus this potential lower risk of blood clots. And I think the answer is evident there. But what I will say is, with the vaccine rollout, it is essential that scientists, these vaccine companies, doctors, everyone who is part of this system acts very conservatively. So when we see, for example, the AstraZeneca situation, I think it is prudent and important for the public to see that this is being widely looked at and addressed, because as we just talked about, we cannot have vaccine hesitancy. It is essential that the public trusts our vaccines and is willing to get them. So I think the sort of process and investigation into this possible side effect of the AstraZeneca vaccine, or possible complication rather, is well performed and important to do.
Very good. And Dr. Greenberg, would you like to add anything to that?
I think that the scientific process for approving vaccinations is a intentionally very conservative approach. And I echo what Dr. Philpott was saying. I think that it's so important that, as things pop up, and remember this happened with the ideas of anaphylaxis, whether or not the risks of anaphylaxis with the vaccine or the anaphylaxis is a severe allergic reaction, is something that we need to be concerned with. And it looks like, we try to balance those risks as we move forward. And all these vaccines are somewhat new, but I actually think that the idea that the AstraZeneca vaccine, even though it's not used in the United States, is used broadly in many countries around the world, and it's been given to many, many folks. And when we have case reports of these particular kinds of complications, we try to figure out, is this the normal rate within the population, or is there an association, not a causation, but an association with the vaccination that was provided? And I think that the idea that we're able to analyze this rapidly and try to make really good choices about what we're going to do, I think is pretty amazing from a scientific perspective. But I think that one other thing that everyone's also looking for, which is another development from the last 24 hours, is the extension of the vaccinations to younger populations. I think that that's something that is a very similar approach. It's a very conservative approach for the extension of, this was an article which was the extension of the Pfizer vaccine to the 12 to 15-year-old age group. And they're working through the process now, and it's a methodical and relative. Some folks are going to think that it's too fast, and other folks are going to think it's too slow. But I think that the key here is they're trying to take a methodical and science-based approach towards making sure that the vaccine is safe and effective in those age groups. And I think that when we look at safety and we look at expansion of either new vaccines or expansion of existing vaccines, I think that the scientific process and the rigor with which it's conducted is, I think folks should be confident that the vaccines that are on the market within the United States are going to be safe and effective.
Very good. Well, Doctors Erin Philpott and Brad Greenberg, thank you so much again for joining us. It's been a while. We missed our friends of the show, so thanks for coming on this morning.
Thanks so much, Megan and Scott. We appreciate it.
We appreciate both of you, and happy Doctor's Day this week to both of you, and thank you for the work that you all are doing.